And now to put the results of the last two presentations in context, we will listen to a discussion from Dr. Polly Niravath from the Houston Methodist Hospital. Thank you very much.
Good afternoon, and thank you to the organizers for allowing me to give this talk, and thank you to the presenters for sharing their slides with me ahead of time. I have no disclosures. Today I'm going to talk about these two abstracts, both of which help us navigate the increasingly complex landscape of early-stage ER-positive breast cancer. The first abstract, number 6, is evaluation of the breast cancer index in premenopausal women with early-stage HR-positive breast cancer in the SOFT trial. Abstract number 7 is results from a phase 3 randomized placebo-controlled clinical trial evaluating adjuvant endocrine therapy with or without 1 year of Everolimus with high-risk hormone receptor-positive HER2-negative breast cancer, SWOG 1207. To first offer some background within this space, we have a plethora of data to guide us. We have many trials which establish the superiority of aromatase inhibitors over tamoxifen. We also have a growing data set to establish the role for ovarian suppression in certain premenopausal women. Many trials have proven a small benefit from extended endocrine therapy beyond 5 years with either tamoxifen or aromatase inhibitors. Adjuvant bisphosphonates are now also included in the ASCO guidelines for certain postmenopausal breast cancer patients. And finally, more recently, we're starting to incorporate adjuvant CDK4/6 inhibitors for high-risk ER-positive breast cancer, with new and upcoming data coming as well. While all this data is wonderful to have, it sometimes leaves us feeling a little bit overwhelmed with so many choices to choose for the patient that's sitting in front of us in clinic. And yet the critical question remains, who truly benefits from more aggressive therapy? So to help us answer this question, Dr. O'Regan and colleagues have designed this retrospective analysis of the SOFT trial to try to identify who may benefit from ovarian suppression using the BCI test. First, to offer a little bit of background about BCI. BCI has already been validated in multiple clinical trials to help predict the benefit of extended endocrine therapy. Most recently at last year's ASCO with B42, in which it was predictive specifically in a subset analysis of that trial. The BCI test, as Dr. O'Regan also told us, is actually comprised of two functional panels. One is the molecular grade index, which looks at 5 genes related to tumor grade and proliferation, and the other is the ratio of HOXB13 and IL-17BR, which are 2 genes measuring estrogen signaling. The prognostic test actually incorporates both of these, the MGI and the HI ratio, whereas the predictive test only looks at the HI ratio, and that is what we're going to be discussing for the rest of this talk today. And as we said, the HI component has been validated multiple times for predicting extended endocrine therapy benefit. Now getting into the crux of this first abstract. As shown here, the results showed that BCI was predictive for ovarian suppression benefit, however, not in the way that was anticipated. It turns out that the HI low patients actually benefited more from ovarian suppression plus AI versus tamoxifen, and the HI high patients did not seem to have this differential benefit. Interestingly, this trend stubbornly held in every subset analysis that Dr. O'Regan showed us, including those patients who had prior chemotherapy or not, the patients who were lymph node positive or negative, and regardless of age or HER2 status. So to try to understand this, we can think about this in both a preclinical and a clinical sense. So we have preclinical data where we know that HOXB13 serves as a tumor suppressor gene, and IL-17BR tends to serve as a tumor promoter. We know that increasing levels of estrogen tend to decrease HOXB13, whereas it increases IL-17BR. So there is a line of thinking that perhaps in estrogen-rich, premenopausal, untreated women, this low HI ratio could actually present an opportunity to predict for estrogen-responsive disease by effectively lowering estrogen very, very strongly with ovarian suppression, which would then lead to a more favorable HI ratio. meaning increasing the tumor suppression levels of HOXB13. Now, in the clinical sense, we know that HI ratio has been validated to predict tumors that benefit from extended endocrine therapy because of endocrine responsiveness and late risk of recurrence. Using that information, we can then deduce that perhaps HI low tumors essentially have high risk of early recurrence, so augmented endocrine therapy in the first 5 years may be more effective for these tumors. Whereas the HI high tumors, because of their later risk of recurrence, may not have as much of a benefit from early aggressive endocrine therapy, and perhaps these patients also need longer-term follow-up to reflect their ultimate outcomes. This data definitely needs further validation, but if it is reliably reproduced in the future, perhaps a future algorithm may look something like this, where ER-positive premenopausal breast cancer patients with an HI low score may be treated with ovarian suppression plus aromatase inhibitor for 5 years, and those with an HI high score could be treated with tamoxifen for 5 years, and then at the conclusion of that time, based on their menopausal status, they may opt for extended therapy based on whether they're postmenopausal or premenopausal. Now moving on to the second abstract from Dr. Chavez McGregor and colleagues, looking at adjuvant everolimus and high-risk ER-positive breast cancer. First, to offer some very brief background on the PI3 kinase AKT-mTOR pathway. As you all know, the PI3 kinase pathway is integral to ER signaling and often mutated in ER-positive breast cancer. It serves as a very common escape pathway, and we have very strong preclinical data to say that there is significant synergism between letrozole and everolimus in inhibiting tumor proliferation. This data then informed the metastatic BOLERO-TRUE trial, which showed a significant progression-free survival improvement with the addition of exemestane to everolimus. Naturally, there's then an effort to move forward everolimus into the high-risk early stage setting. SWOG 1207 then takes patients who have high risk due to significant nodal disease or high genomic risk and randomize them to endocrine therapy with or without 1 year of everolimus. As we just saw, the trial did not meet its primary endpoint of improved invasive disease-free survival. While this negative result is extremely important on its own, it bears even more importance when we look at the larger context of other trials which have posed similar questions. For example, the timing of the mTOR inhibition strategy appears to be very critical. We see that in Gephardt-Quinto, which was an early-stage ER-positive breast cancer trial, which looked at patients who were resistant to neoadjuvant EC and were then randomized to weekly Taxol with or without everolimus. As you can see from the graph here, this trial showed no significant benefit. Similarly, Jenny Chang's group looked at neoadjuvant mTOR inhibitor plus tamoxifen and found very minimal reduction in Ki-67 at the time of surgery with this strategy. And finally, the very similar UNIRAD trial to SWOG 1207 also looked at an extremely high-risk ER-positive group and actually had to end early because of futility at the first interim analysis, with no apparent benefit of the addition of everolimus to adjuvant endocrine therapy. Taken together, this data leads us to conclude that early-stage ER-positive breast cancer may not benefit from mTOR inhibition, perhaps because it tends to be a later escape pathway that cancers develop as they become more aggressive. However, it is extremely important to note that the premenopausal subset within SWOG 1207 did seem to respond better to everolimus. While this is hypothesis generating, it also adds several other questions, some of which were mentioned. One question was, did premenopausal women have better compliance with everolimus, or is there something different about the biology of premenopausal ER-positive breast cancer? We would also like to see how the choice of endocrine therapy specifically within the premenopausal subset may have affected outcomes. And furthermore, even if this were proven to have an effect in premenopausal women in the future, how would this then fit into our current landscape of so many treatment options that we have for many premenopausal breast cancer patients? But I think we cannot leave this abstract without also discussing the elephant in the room for most adjuvant endocrine therapy clinical trials, which is that of compliance. As you can see here, only 48% of patients randomized to the Everolimus group ended up completing their therapy. And similarly, most of them actually stopped due to adverse events. Unfortunately, this is not an uncommon situation. As you can see here, more than half of the patients in SWOG 1207 and UNIRAD discontinued treatment early. Similarly, in the PALIS trial, we saw that 42% of patients discontinued palbociclib. A similar amount of patients discontinued palbociclib and abemaciclib in Penelope and Monarchy, respectively, because of side effects, and some of this data is still coming out. This trend for low compliance due to increased side effects is very troubling for several reasons. One is that obviously we may end up with falsely negative trials where very promising agents appear to not confer benefit only because patients are unable to tolerate the medications. Perhaps even more importantly, when these drugs are found to be effective and then used in standard clinical care, we are unfortunately sentencing many of our patients to a very significantly decreased quality of life. This ultimately ends up shifting the symptom burden to the patient rather than we as the physicians understanding what the toxicities are and trying to proactively prevent these to help improve compliance and adherence for our patients. So, where do we go from here? There's definitely still a lot of work to be done. While neither of these trials are practice-changing, they do represent our ongoing quest to find tolerable and effective treatments which are rationally tailored to our patients. So in the future, we would do well to focus on trials that actually have a very strong focus on compliance and tolerability. So what would this look like? In my opinion, it would mean a stronger emphasis on patient-reported outcomes in trials, as well as proactively writing into our protocols more aggressive dose reduction for adverse events, and similarly putting in specific algorithms for symptom management into the trials when we know that certain drugs are associated with very strong and predictable adverse events. I also call for a greater federal and private funding for symptom management and survivorship studies, because patients can only get benefit from the drugs that they're able to take. This would allow us to serve our patients as whole people as opposed to breast cancer cases. Furthermore, in the future, as we improve our understanding of genomic testing and minimal residual disease, I would hope that we can start to offer more effective, tailored therapy to the patients who truly would benefit and truly have the highest risk. And finally, especially as we move on to newer therapies, such as ovarian suppression, which may have very, very long-term effects that could affect overall health, it's very important that we continue to follow these patients for their overall outcomes and their breast cancer outcomes. So in conclusion, both of these abstracts should be applauded for laying a few bricks in this very long road that we are on to improve breast cancer care for all of our patients, in the hopes that we may someday feel more like this version of Homer Simpson than the other one. Thank you.
Thank you, Dr. Niravath, for your very thoughtful discussion.